Dr. Ospina. How are you today?
Good. How are you guys?
Good. So nice to meet you.
Mhm.
Thank you so much for spending this time with us today. Thank you, PMD Alliance, for sponsoring this, and Teva Pharmaceuticals for funding this amazing program called Lunch with Docs HD. And this is going to be a every third Tuesday of the month free webinar series. And today we have Dr. Maria Cristina Ospina. Ask Dr. Ospina.
So I'm a movement disorders neurologist. I'm in private practice here in Phoenix, Arizona. And then I also have 2 days of clinic a month down in Tucson at the university, which has also been bought by Banner. So I think now they're at the Banner Medical School University, something or other. But I mostly spend most of my time in private practice in Phoenix. And we used to have a Parkinson's sort of comprehensive clinic at Banner Good Sam, but that disbanded a number of years ago now.
Now, will you guys be working with the Huntington study, the HDSA?
At Barrows.
So is that going to be a center of excellence?
Yeah, so my understanding is that it will be a center of excellence, and they'll be involved in all the clinical trials. And so Banner actually took our nurse, so we send all our patients, if they are interested in trials, to Barrows. The ones that live in Sun City go to the Sun City Research Center. And of course, we also have Mayo here in Phoenix. And then in Tucson, they go to the university. So we don't do clinical trials anymore in our clinic. We've moved facilities and we're in a much smaller space now. So we actually don't even have room for all the binders and folders. And so we do most of them through Holly Shield at Barrows.
And is that also HSG for PD and for HD?
Yes. Uh-huh.
Oh, fantastic. That's wonderful. Mm-hmm. So part of your background is in deep brain stimulation.
Uh-huh.
Can you talk to us about that a little bit? Tell us what it is, first of all, and how it works in the brain. Mm-hmm. What is the pre-op and what's the post-op, and are you doing it for PD and HD?
Yeah, so DBS, or deep brain stimulation, it's been around in the US about 20 years. And what we do is we put a stimulator deep into an area of the brain to help both Parkinson's. So in the US, we use it in Parkinson's disease, essential tremor, and dystonia. So in Parkinson's disease, we have 2 different places in the brain, the SDN and the GPI, where we put the stimulator. And for essential tremor, we put it in the VIM or in the thalamus. And what it does is it quiets the brain in that area and allows you to reduce the tremor. Or in Parkinson's disease, when patients have on time with dyskinesia, so they take their medicine, their levodopa, and then they get dyskinetic movements, like you see Michael J. Fox on TV, and he's kind of dancing around, that's dyskinesia. So the DBS allows you to take your medicine, your levodopa, without having dyskinetic or wiggly movements. And it also allows you to control the tremor that we either can't control with medications, or we have to get such a high dose of medicines that the side effects interfere with taking the medicine. So DBS allows us to quiet the tremor in both Parkinson's disease and another tremor called essential tremor. So essential tremor is something that runs through families. So if people remember Katharine Hepburn, she had essential tremor or a dystonic tremor, and it usually involves both hands, and it can involve the head and the neck, and you can also have a vocal tremor, and we treat the vocal tremor with Botox. So many people, they confuse essential tremor with Parkinson's disease. And the difference there is that essential tremor, it's a bilateral tremor, so both hands have the tremor, and it's a tremor with action or kinetic. So you're going to go and reach for a cup, or you're going to use your fork, you're going to use a spoon. And so as you're using that utensil, you notice the tremor. Whereas in Parkinson's disease, it starts unilaterally, the symptom starts on one side, and it's a resting tremor rather than a kinetic tremor. So that you're sitting watching TV, and then the little finger or the thumb has a little bit of a tremor, and then can involve the hand and then the feet as well. So DBS is very good at controlling that kind of tremor. We also use it in a disease called dystonia, which it's basically an involuntary contraction of a muscle. So many times you'll see patients with cervical dystonia where their neck is moved to one side and they can't put it in the neutral position. And so we can either use Botox for that, or we can use DBS, or there's something called DYT1 dystonia that you see in children, and we also do DBS for those dystonic patients. So far, it's experimentally done for Tourette's. There's a trial for epilepsy and as well as for depression, but it's not commercially used for that, and the insurance doesn't cover those. And we don't use it in Huntington's, although there is one patient at Mayo where they did a bilateral GPI for chorea. But that's one case. So we usually don't use it for Huntington's, but we use it a lot for Parkinson's disease. So it's a deep brain stimulator. It sounds kind of scary, but it's not very invasive as far as surgeries are concerned. And the recovery is very minimal. So everything you were doing before, the day before surgery, you're doing the day after surgery. You only spend the night in the hospital because we actually went into the brain. But, recovering from a hip or a knee or a shoulder replacement is a much more difficult surgery and a much more difficult recovery. As far as, using the DBS, it does take weeks to months to program the stimulator to dial out the tremor and dial out the dyskinesia. So it's not something that we flip the switch and boom, it's all done. It's something that does take time. So just like we don't titrate your meds all at once from one day to the next, we slowly do it over time. And we do the same thing for DBS to let your brain and body get used to the stimulation. And now something that's exciting is that there's 3 different companies providing DBS hardware in the United States. So we're going to see a lot more innovation come a lot faster with directional leads, with batteries that are rechargeable and last a lot longer. And then the hardware itself is going to get much smaller. And today we can also do your DBS surgery asleep. You no longer have to be awake. And so it's a much easier surgery for the patient to tolerate. What other questions do you have about
That's a little scary.
It sounds scary, but really a knee replacement is a much more difficult surgery, or a hysterectomy is a much more difficult surgery, and it involves much more recovery than DBS does. And so it kind of sounds scary, but really all we're doing is dropping a lead down and that's it. And then the rest is just like putting a pacemaker. The battery goes under, it's subclavicular, and that's outpatient 40 minutes in the OR, and that's it. So,
that's great. And what is the lifespan of the battery at this point? And now you have competition with other products, so that's great. But
yeah,
right now,
for the Medtronic's battery, so you've got the PC, that's about 2 years, 2 to 3 years, more like 2 years. And then they have a rechargeable battery that currently is 9 years, which will more likely turn into a 15-year battery later on. Then the Boston Scientific battery is rechargeable, and that's a 15-year battery. And then, and so for the rechargeable batteries, you can either charge it every day, and that's about 10 to 15 minutes, or if you want to do it once a week, that's about an hour to charge it. And then the St. Jude battery, again, 2 to 3 years, and they haven't come out with a rechargeable one yet.
Fantastic. Well, let's talk about the Botulin Toxin, because that's come up in my realm as a caregiver a number of times, and doctors are not readily willing to use Botulin Toxin for spasms. They're telling me, they use them for headaches.
Yeah.
Can they be used for spasm? For example, a lot of our HD folks have bladder spasms, muscle spasms in other locations of their body. And I'm just kind of curious to know if that's something that could address the spasms.
So botulinum toxin, again, for that, there's also 3 different companies too, so there's choices. So we use, as movement disorders neurologists, we use Botox a lot. So we use it for dystonia. So the patients who have cervical dystonia, that's the first line of treatment for them. We, inject Botox into the neck muscles to bring them back to midline. In Parkinson's disease, we use Botox several different ways. So for dystonia or a spasm of a muscle, so if you have a dystonic muscle or the foot keeps turning in and we can't fix that by giving you better on time or less off time, then we'll Botox those dystonic or contracted muscles to let them relax and let the limb go back into a neutral position. And then we can also use it for drooling in Parkinson's disease. So, many times in Parkinson's, what's happening is not that you're producing more saliva, as you're producing less, but you're not swallowing as often as you used to. So in Parkinson's, all of the muscles of the body move slower, including the muscles of the gut and swallowing and the blinking. So because the patients aren't blinking, the eye dries out and gets dry and itchy. And because you don't swallow as often as you used to, the saliva tends to pool and then drool out. So one of the treatments for that, siluria, is that we can Botox the submandibular glands and kind of shut them down and to try to control the drooling as much as possible. Sometimes what happens with that is that the parotids take over and they say, hey, the submandibular glands aren't doing their job. I'm going to make more saliva, and then we're sort of but it's something that we do use Botox for drooling.
Does that happen in HD as well?
If there's a lot of drooling, then we can do, it's the same procedure for both Huntington's and Parkinson's disease. But Parkinson's tends to have a little bit more trouble with swallowing because of the bradykinesia, the slowness of movement, the lack of swallowing is more pronounced in Parkinson's disease. In Huntington's disease, you have chorea, so you have these extra movements, and that can interfere with gait and balance, and that can cause falls. And then if the chorea is severe enough, it can cause trouble with dysphagia or swallowing. And then that can cause, drooling as well. But it's mostly seen in Parkinson's disease, and we do use it a lot in Parkinson's patients.
Do you see many late stage HD individuals?
So usually what happened, we tend to see them sort of in the middle part of it, because once they're end stage, they end up moving into a nursing home, and then they're seen by the nursing home physician, and it's difficult for them to travel and to get transportation out to an outside neurologist. So we don't see as many end stage HD as we used to. In Louisiana, we had a clinic that was a telemedicine clinic with one of the nursing homes, and so we had a lot of end stage HD then, but that was only because we had telemedicine straight into their facility. So what we find is that, when patients end up in a nursing home and it's hard for them to travel, we don't tend to see them as often.
I've noticed that Parkinson's has more telemedicine opportunities, especially for the facilities.
Yes, I think
they're trying to do that for Huntington's now too. It's just taking a little bit longer.
Right. So I think, number one, the Parkinson's community is much bigger than the Huntington's community. So it's about 1.5 million PD patients in the US, where it's only about 30 to 40,000 HD patients in the US. So, it's much easier for the PD people to find each other and make a community and start to make things work. But the other thing is that, Medicare and insurance companies are very slow, especially Medicare, to get on, to join the 21st century and realize that, oh my gosh, I could actually talk to my doctor from my phone in my house or my office or even from my watch. But, many times Medicare puts up a lot of barriers. Where, we used to have a Skype clinic in Flagstaff, and then Medicare said, well, the Skype thing isn't HIPAA approved and it can be hacked and it'll end up on YouTube. And so, they wanted us to use this very expensive equipment that cost $100,000. Then in this clinic, it just didn't work. But I think that the future of medicine will be using telemedicine. I mean, there's no reason, especially for follow-ups for things like HD and Parkinson's disease. And if you live 5 hours away, there's no reason that you need to come in and be seen physically every single time. Like once you had your original diagnosis and we've checked for the cogwheel rigidity and your bradykinesia, we can see your exam quite well on telemedicine without any problem. So I think once Medicare and the government catch up, that will be the future. And then, you know, people who are in nursing homes will have a lot more availability of specialists.
That'll be a good thing.
Right. Or like people who are homebound, you know,
right.
Well, why do you need to go anywhere? Like if you're at home and you're not driving, I mean, I guess by then we'll have driverless cars. You'll just get one of these things that drives itself.
Jump in at the front door.
Yeah, exactly. Goes to the front door.
Take me to the doctor.
That's pretty cool. That mobile, it's still difficult, even if you're not physically driving the car yourself, to get in the car, get dressed, all of that stuff. It's much easier for you to turn on your computer and see the doctor there.
Right. Now, getting back to the speech difficulty, I know, or swallowing difficulty, I do know that especially with late stage Huntington's, that they're having difficulty swallowing and choking and you know, things like that. They have issues with you know, swallowing down the wrong pipe and that kind of thing. I noticed on your information that you're an advocate of therapies, speech therapy, occupational therapy, exercise, and things like that. So is that something that you refer out, or do you have in-house people to work with your HD individuals that may need some therapy? And is this an ongoing thing? Can it be done throughout the disease? How do you?
Yeah, so especially for Huntington's, where we have a limited number of medications that are approved for the treatment of Huntington's, then we use a lot of the supportive treatment like physical therapy for gait and balance training, speech therapy to help with the swallowing, occupational therapy to help with dressing and bathing. So, you know, that's something that we refer out, and usually to some place that's close to the family, so that it's easy for you to get there, whether it's outpatient or in a hospital system. But something that we would keep going, you know, using it all of the time. And so Medicare just changed the rules, whereas before I think you only had 18 visits a calendar year. So it's either starting this year or 2019 that for 2 years, chronic diseases like Huntington's, Parkinson's disease, strokes, that sort of thing will get unlimited physical therapy and speech therapy visits, so that we don't have to keep playing this game of to give you, you know, 12 visits for Parkinson's and then 12 more visits for your hip or 12 more visits for your back pain, so that we try to give you continuous physical therapy and speech therapy if it's possible. And it's something that I think you should keep going as long as.
And what happens after 2 years? Because we know that, you know, especially with Huntington's, it's a very long-term illness. So 2 years is like a drop in the bucket.
Right, exactly. So then again, we write the congressman again, and we do our letter writing campaign, and then they make a new budget, and hopefully it'll be included in the new budget again. So it's this constant fight, you know, because they're always changing the rules, they're always changing what goes in and out of the budget. And so, you know, we have to be advocates for ourselves and our kids.
We do.
And then always keep writing your congressman. Because, you know, if we don't talk to them, then all they're hearing is from the big lobbyist, not the little lobbyist.
The mommy lobbyist.
Yeah, the mommy lobbyist, exactly.
Mommy lobbies.
Right.
Can we talk a little bit about apathy? And then there's one subject that I'm getting a lot of questions on.
Sure.
We'll get to that one after. I want to talk about apathy because I know that's a big thing with HD, and I know, you know, it happens with everything, every neurological or brain disorder. But how can we anticipate working with apathy and trying to motivate them to do certain things that we need to have them do, because that seems to be a big problem.
Yeah, so Huntington's disease it's a disease that has three different parts. It's a genetic disease. So if you have the gene, you're going to get the disease. And sort of 50% of the offspring of Huntington's patients have a chance of getting that gene. And then, but you're only seen by the neurologist once you develop the chorea, but you've actually had Huntington's your entire life. And that neuropsychiatric part of Huntington's has been present there the entire time. So trouble with impulsivity, that fact that that filter isn't there, all of that has been part of the patient's makeup and how they interact with the world. So many times by the time they're seen in the neurologist office, when the first motor symptoms of chorea have developed, the patient may or may have already lost a job or had a divorce. So the symptoms of Huntington's have already been there. The apathy, and so those are patients that tend to be more impulsive, have harder times keeping social connections, those sorts of things. And then the apathy mainly comes with the dementia. So that third part of the disease where you have the cognitive decline and the dementia that comes in, then patients with dementia tend to have more trouble with apathy rather than impulsivity and sort of those manic type of symptoms. So there's apathy and abulia. Initially, we treat those neuropsychiatric symptoms with things like antidepressants to help the anxiety, to help the depression, to help kind of tone down that impulsivity, bring back that filter if possible. And then once the dementia starts to set in, we can treat that with dementia medicines. Those medicines, they don't stop or reverse the dementia, they slow the cognitive decline down. But the more alert and attentive we can keep the patient, the easier it is for us to manage that apathy, but it's extremely difficult. So, because the patient, as the disease progresses, there's like less verbal output, there's less that they're actually initiating. All of the conversation activities are being initiated by the family or the caregiver by the time abulia or apathy is starting to kick in. So we want to be aggressive in sort of treating those things early on and trying to keep them engaged and attentive in the real world as long as possible. So again, we treat the anxiety, we treat the depression, we treat the dementia as much as possible, and then try to keep them engaged as much as possible. But that is one of the problems.
So you're saying that the apathy increases as the dementia increases?
Right. So as dementia increases, then the patient appears more apathetic. They're less engaged in what's going on. There's less verbal output. So when you're speaking with the patient, they're just answering yes or no. They're not really engaging in the conversation. They're not asking you questions. And when you do ask them a question, they give a very short answer. And it's part of the dementia that they have less attention to what's going on. So things like dressing and bathing, the fact that they hadn't bathed in 3 days, it doesn't, they don't remember. It doesn't really register. It's always that you're kind of providing the input there. So go ahead.
They lose their ability to remember what has transpired in the last few days, hours, weeks.
Right. So with the dementia, then yes, so short-term memory no longer gets turned into long-term memory. So, they may remember what they did 40 years ago or their high school reunion, but they can't remember what they had for breakfast yesterday or whether they had breakfast today, whether they took a shower today or not. And then those things become less salient. It's not that important to them whether they changed their outfit or their t-shirt or not, or they washed the sheets. It just doesn't register anymore. So it's part of.
I can relate to that.
So it's part of it. Just doesn't, reach the attention part of the brain. It just doesn't register.
It's not something that they're doing on purpose. It's just something that is not in their radar.
Exactly. That's a good way to put it. It's not on their radar. And
right.
And that's something that's super important for both the caregiver and the patient to understand, that the patient isn't doing any of these behaviors on purpose. Mm-hmm. This is just the disease. And so they're not just blurting these things out to be mean or say these comments to be mean, is that that filter that we all have isn't present in Huntington's disease. So where we think about, oh, maybe I shouldn't say that, it just gets blurted out. There's nothing that says, oh, let me think about the statement before I say it. Would it be appropriate or not?
There's no filter.
Yeah, there's no filter. And so they're not going around, you know, saying these hurtful things or these things that seem insensitive on purpose. It's the disease. And then once the dementia kicks in, you know, they're not just sitting there on the couch and not helping with the laundry because they want to sort of stick it to you. It's just because that they have Huntington's. It didn't register them that there are dirty dishes that need to be put away or that the dishwasher needs to be emptied. Is, like you said, it's not on the radar.
Okay, here's a subject. There's a series of questions, I'm sure, but there is a subject, and it's sex with HD. So part of that is, you know, intimacy, relationships. What happens when a young person is divorced now and they have Huntington's, they want to date? I mean, how do we go about, you know, helping them to kind of screen out, you know, the people that could potentially take advantage of them or misuse their.
Right. So I think, you know, that's really important then to have things like healthcare proxies. You have, you know, a power of attorney and those sorts of things, because the HD person isn't going to be able to make, you know, judgments about what they should do with their disability check or what they should do with the money that's in their savings account. For them, they might wake up one day and be like, hey, I'm going to go to Las Vegas with this guy I met at this bar yesterday, and then spend all the money. And so, you know, they no longer have the judgment to make those decisions of, is this a good idea? Should I spend the $700 going to Las Vegas and drinking it all away? Or should I spend it on my assisted living or my group home or that sort of thing? So that's why it's important to have sort of a legal guardian that can make sure that those things are being spent the right way, and then put some limits. You know, it's just like you wouldn't let a teenage girl, a 15-year-old girl, say, hey, I'm going to go off with X, Y, and Z. You know, they again, their frontal lobes aren't fully connected as well, so they can't make those judgments. So with HD, it's that they're being disconnected.
Mm-hmm.
So they definitely need guardianship.
So how would you go about addressing that with somebody that they're adult, you know,
Right.
they make their own decisions, but yet, you know, here they are alone, they're divorced. There are no family members around maybe that are willing to, you know, step in and take that guardianship seriously.
So
How
I
would
think,
you?
I mean, in those cases, you can always do neuropsych testing so that patient can see in black and white, look, I don't have the skills. Although if they've reached that point, they might be able to read it and it doesn't really make that much sense to them and say, well, I don't understand why I can't decide what I want to do with my disability check. I mean, I think that's unfortunately, if there isn't anybody there to step in, you know, these are patients with Huntington's. They don't have the judgment anymore to make those decisions. So family or society needs to step in and make sure that the welfare of that patient is looked after.
Mm-hmm. Now, the other side of that coin, I have individuals in support group situations where there's a lot of behaviors that are abusive, I guess you'd call it, also scary behaviors, and yet one day they're fine, the next day they're, oh, you know, they're so nice to me. And I had one person say, you know, should I have sex with this person? I'm like, well, you know, if he's not abusing you, yeah, why not? You know, you're married, you know, you have to have a relationship with your loved one, you know.
So is it that the caregiver is becoming frustrated and then abusive to the patient?
No, the patient is, you know, striking out, becoming frustrated, and, you know, threatening and things like that.
Yeah, so then for the patient, then that's the Huntington's disease, and that's the neuropsychiatric part of the disease.
Mm-hmm.
And then we would go ahead and treat that. So, we can use medicines that block dopamine, that kind of blunt that aggressive behavior and that abusive behavior. So just like we would treat hallucinations, we would treat that as well. But it's something that needs to be brought up to the physician, because if the physician doesn't know about it, they're not going to be able to address it. But that is all part of the Huntington's disease. And then what's important is that we don't want that to be a reason why the patient loses their independence and their home life and ends up in a nursing home, because now they're striking out, they're frustrated, they're angry, there are all these outbursts, and the family can't have that in the home. Right. So it can be treated medically with medication. And then if that allows the patient to live at home with the family, I think that's preferable than ending up in a group home or a nursing home.
And I think the question is, at what point do you have to take over, medication administration, management of, things that normally they would be managing themselves?
So I would say it's sooner rather than later. So, especially in this society, we're like, oh, everybody's an individual and they can make their own decisions. And, I shouldn't be overstepping and being the mommy all of the time. But the patient has Huntington's disease. They no longer have the ability to make these good judgments, or they have dementia. They can't really think things through. And so even though they're still walking and talking and dressing and bathing, they may not be able to take their medicines on time and take the right medicines. And so I would say that it's better to intervene earlier rather than later. We're always trying to say, we don't want to overstep into that person's individuality, but we have to realize
independence.
Their dependence, right? Mm-hmm. But always safety first. So yes. You don't want the patient to accidentally take too much medicine or too little medicine because they didn't remember what was going on.
Yeah. Okay, so here was one of the questions, and this is relating again to relationships. It says, should a recently divorced woman with early stage HD trust her neurocognitive function to begin dating online or in person, to become sexually active, to make commitments?
So I would always say, have a wingman, have somebody there who's like your outside brain that's saying, just like anybody would, oh yeah, especially with online dating, to sort of vet these people with you and for you to make sure that you're not getting yourself into trouble. And it's certainly not, we had one patient, especially with patients who have dementia, it's very easy to become prey to all these scammers, and especially these online things where they promise you the world and you keep sending them all this money. And then, in the clinic, it's very difficult to talk these people out of it and say, look, no, this guy's never going to come and marry you, but please stop sending them money.
You heard that one too, huh?
Yeah. So, and it's heartbreaking because, they push all the right buttons. And of course, everybody wants to have a partner in life. And then they're not able to objectively step back and see, well, why would this person who always says that they love me always keep asking me for money? And then make up all of these excuses of why they can't be seen in person.
Right.
So, these things happen. And so you always need somebody there to vet the person and help you out.
And that happens to people that don't have HD.
And that happens exactly, even to people who don't have HD. And so, but with HD, you don't have the cognitive processes to think your way out of it, to connect the dots and say, oh yeah, he keeps giving me all these excuses of why we can't meet, but he keeps asking me for all of this money.
So sad. So, I can't think of anything else, right? Oh, I know I was going to ask you. Have you heard of laugh therapy?
So, I think laugh therapy is always good. It's good for everybody, not just Huntington's patients or Parkinson's patients. So you can do laughter yoga, all of those things, music therapy. So, one thing you were talking about with the apathy beforehand, Music is a good way to like synchronize yourself with the other person, and then, they become more pro-social. Babies do that as well. So that if you synchronize to the same music, then in babies, what the studies show, that the babies were more likely, so if you're like trying to reach for the cup and you can't quite get it, the baby's more likely to help you go get that cup if you were both like dancing to the same beat kind of thing.
Yeah.
So the same thing can work with patients with dementia, with apathy, using music therapy.
What about pets?
Pets are very good. So, pet therapy, always having a dog, so that, especially with falls, dogs that are properly trained can help you with gait and balance. And certainly they can, especially if you live alone or with somebody else, then they can alert the other person when the patient fell, or especially like with seizures, that sort of thing. So, I'm all for pet therapy, having a pet companion, and then doing all these alternative things like music therapy, yoga, all of that kind of stuff.
So tell me, what is next for you with HD? Are you going to be working with clinical trials at all? Are you looking for
the trials were done through Barrows, and we would just send the patients there, and then we see patients here in our outpatient clinic.
So you're not involved in any of the clinical trials?
Yeah, we won't be involved in the actual physical clinical trial.
Darn.
And we don't have the space for it anymore in our new facility.
It is hard getting people to clinical trials.
Right.
So maybe those new self-driving cars can help with that too.
Right. So, I think transportation is a big problem of why patients don't want to participate in the trial, especially if there's many visits that are implicated in the trial, and it's hard for them to get in and out of the house, get dressed and all fed and all of that stuff. And then to like drive across town, that's also difficult, or get dial-a-ride. It takes forever for dial-a-ride to get to your house, and then it leaves you there in the clinic all day. So transportation is a big reason why patients don't participate. But just, we need the volunteers. Without the volunteers that do the clinical trial, we don't get the new medication.
Right. I know HSG is working with some new pharmaceutical companies. So I'm hoping to see some new clinical trials coming up, and then with the Ionis and Roche trial. I don't know when that will be coming to the US, but hopefully soon.
Right. So eventually we'll have nanobots that do origami, and we'll refold all of these misfolded proteins.
Wouldn't that be great?
Right. Well, it sounds like science fiction, but that's, so was the iPhone 10 years ago.
Right?
Mm-hmm.
Are you prescribing the Austedo?
Yes.
And how is that going? Can you talk about that at all?
Yeah, so Austedo is a new form of tetrabenazine. So tetrabenazine we've been using for tardive dyskinesia and Huntington's for a long time. And before that, we were getting the tetrabenazine from Canada. So what tetrabenazine does, or Austedo does, what happens in Huntington's is there's too much dopamine in the system. And so the Austedo is a way for us to, dial down all the dopamine that's in the system. And therefore you have less of these involuntary movements of the chorea. So the Austedo and tetrabenazine, they only treat the chorea portion of the disease. They don't treat the neuropsychiatric part of it or the dementia part of it. And in fact, it can make the neuropsychiatric part worse. It can cause more trouble with depression. So it's important to always be communicating that with your physician, so that if that happens, it's dose dependent. We can lower the dose, make you less depressed, but still control the chorea. So Austedo, basically, it's a twice a day form of tetrabenazine, which we would take 3 times a day. And they've replaced one of the hydrogen items with deuterium, and maybe that's too technical, but it metabolizes slower, so we can take it less often with less side effects. So many patients with the tetrabenazine had a lot of sedation with the medication, and with the Austedo, they have less of the sedation, sleepiness.
Have you seen any change in the spasms with this new Austedo?
No, I mean, I've seen that, there's better gait and balance because we've controlled the chorea a little bit better. And then controlling the chorea, we have less of the swallowing issues if the swallowing was due to the chorea. So with less extra movements, you have less of all of those kinds of problems.
But have you heard of that happening with HD, with a lot of spasms?
Well, you can certainly get dystonic or dystonia. And then, if it's just sort of muscle spasms or muscle cramps, you can, just take some magnesium for that, 200 to 400 milligrams a day. And that will help you, especially with exercise-induced cramping.
Mm-hmm.
Then that will help that.
We're having a lot of bladder spasms.
Oh,
So thinking maybe part of it could be from different medications, or
or you could visit with the urologist and see if any of the medications work. And then with the medicines, always you want to make sure that the benefits of the medicine outweigh the side effects of the medicine. So if you take it and the bladder spasms get better, great. If all you get is low blood pressure and dizziness and confusion, stop medicine.
Right.
But I think it's always worth giving it a try, and then but be quick to chuck it if it doesn't work.
Yep. Well, yeah. And then there's not a lot of pain with HD, but I hear a lot more people do have it than not.
Yeah, so certainly if your muscles are cramped or if you have a lot of chorea, so a lot of the involuntary movements and you're moving around all of the time, not only are you losing weight because you're burning calories, but that's fatiguing to the muscles. Mm-hmm. So, and that's, just like if you went and, climbed up a mountain and the next day you have that lactic acid, that the muscle pain from that, the same thing can happen from the chorea because you're using your muscles all of the time and they get tired and they get fatigued, and that can be painful. So that's why, like the HD patients we're always worried about their weight if they have a lot of chorea because they're burning all of the calories. They're burning more calories than they're taking in, especially if they have swallowing issues.
Do you see very many comorbid conditions like diabetes with HD or any other kind of conditions?
Not so much. I was just thinking, even with Parkinson's, we had a patient today that had a stroke. And I was thinking, gosh, it's so unusual in our clinic that we see, PD with something else, like a stroke or something like that.
Or different cancers. Have you seen?
Cancers, yes, you do see that. So with Parkinson's, they're more prone to things like melanoma. So with Huntington's, I don't really see that many other things. But in Huntington's, patients die early. So, they're not 90 years old with congestive heart failure and, prostate cancer and those sorts of things.
It's so strange how they could be, in their 40s and be diagnosed, or even be in their 60s and then be diagnosed with it.
Right. So usually the chorea starts in the 40s and 50s. Some in the later onset started in the 60s. So, not more like 60s. It depends how many repeats you have, too. And the thing is that the patient has had Huntington's the entire time. So just because you just notice they have chorea, they didn't get Huntington's, when they were 45. They had Huntington's the entire time. And that's why, where you're talking to the family and the caregivers, all these interpersonal things of, what mom was doing when they were 12 and her, irritability and her, fact that she sort of came and went, all of that was Huntington's disease. She wasn't really doing that on purpose.
And then at what point is disability given to an HD person?
So, in my clinic, we give it right away, but, in our clinic as a neurologist, by the time they're seeing us, they're developing the chorea. But by then, the neuropsychiatric part has already been there, and it's made it difficult for the person to maintain a job. So the thinking has slowed, and then certainly if they're in things like engineering or sales or anything like that, these extra movements are going to interfere with their ability to keep a job. So we give disability right away, usually.
My husband was he was a policeman. He was a motor cop for 30 years
Mm-hmm.
and started showing the chorea at about 25 years in.
Mm-hmm.
And, you know, they thought he was drunk.
Right. Uh-huh. Uh-huh.
But now my son doesn't have chorea.
Uh-huh. Uh-huh.
So it's weird how they're all different.
Yep, they're all different. Everybody progresses at their own rate. So it's not a cookie cutter thing.
No, it sure isn't. Well, I would just want to, again, thank you for your time.
You're welcome.
For spending this hour with us,
Sure.
answering all these crazy questions.
Of course, of course.
And, we appreciate your time so much. And thank you to PMD Alliance and Teva for funding this. And look forward to hopefully seeing you back on Ask Dr. Ospina again.
Sure,
sometime
anytime.
in your future with more questions.
Okay. You take care.
Thank you, and have a great month. We'll see you all on the next third Tuesday of the month, Lunch with Docs HD. Everyone have a great month.